All right. So probably you've seen those, we call it 1 or 2 pager for the covered procedures. This is, and the screenshot that you see is the part of our F Woman manual. So in F Woman, we have quite a few pages that list all the procedures and appropriate ICD-10 codes. We're going to talk about what is, CPT and ICD-10 codes just, in a moment. And there is quite a few tables, but if the providers wants to see just, a brief summary of all the procedures, it will be on this, 2 page at the end of F Woman. If something is not listed, it means it's not covered. And usually when we come up with the new benefits, it usually takes quite some time, to get it approved. We had stories of not having approved procedures sometimes even for 6 years. So a lot of things depends, unfortunately, on other people who are fiscal, who sometimes don't really see direct correlation between quality and quantity. Oftentimes, it's really a fight for the new benefit. Nevertheless, that's what, one of our, major duties at the section is to make sure that we have all the appropriate benefits and our women are served with the entirety of the procedures for breast and cervical cancer. So with that, I'm going to say it one more time. It is super important, the disclosure. This disclosure hopefully will be in the regulations, which is kind of, the regulations that we don't have yet. The regulations is pretty much kind of a summary of EWC laws. So what, has to happen, absolutely what has not, what should not happen, in the program. And we will have a special, what we call public period for the regulations to be reviewed by you and by general public. So we're waiting for this regulation, and this, phrase is actually comes from the regulation, and it states that PCP and referral providers agree to disclose any not-covered services to the patient and receive their written authorization before services is provided. Because, as you know, we absolutely cannot, bill or balance bill our recipients. So if something is provided outside, please make sure that providers are aware of what they're supposed to do. Um, Also, providers should, inform patients regarding the costs, to the recipients, and recipient must sign the disclosure. Just yesterday, I received the question from one of our clinical coordinators. One of the clinic is kind of reviewing their budget, and they want to see if they need to hire a special person who will put things into DTAC. And I thought that, I would mention it today is that there is, a rate table from the Medi-Cal. So the reason we are, with the Department of Healthcare Services, I think I've talked about it. It's because we're using fiscal intermediary for Medi-Cal. And therefore, we're also utilizing Medi-Cal rates for the reimbursement. So our rates are exactly the same, and those rates, can be found on the Medi-Cal website. Usually, I just Google. I just, Google, Medi-Cal rates, and you'll have the link to the rate, and then you have to download, tables and tables, with different codes. But those tables, they list basic rates. So when the reimbursement comes, it may look somewhat different, but it's really based on, provider type, modifiers, etc., etc. But the basic rate, can, is a public information. So I just wanted to mention that. Um, oops, apology. Um, so let's make sure that we understand the abbreviation. So let me go back a little bit. So when we talk about, covered procedures, as you can see, there is CPT codes and also HIPICS codes. So these are the code that we call procedural code. So the code is for procedure. And although we call it procedural code, it can be for the office visit, it can be for a procedure, it can be for a lab test, but this is procedural codes. This is what doctors do in order to serve the patients. But they have to submit the claims with ICD-10 codes. And ICD stands for International Classification of Disease. What is that? It's pretty much the code for the diagnosis. Why those two things are combined and why it is so important, that providers submit the appropriate code. In the past, when we did not have this in place, our patients would have been seen in emergency room, at the office visit, but they can be seen for things like even appendicitis or, diabetes, hypertension. So anyone can bill us for the office visits regardless the nature, of the disease. And as you know, we are a payer of the last resort. So for us, it's extremely important to make sure that our funds are only spent for breast and cervical cancer. So when providers submit the procedural code for which there is a certain reimbursement rate. They have to submit it at least, there's usually two codes on the claim, but at least one code needs to be with appropriate ICD-10. And those codes are listed in our list of the covered ICD-10 codes in the beginning of our chapter about the reimbursement. So each procedure usually has list of appropriate codes. We divide them into three tables, table 1A, 1B, and 1C for cervical, and then 1A and 1B for breast. And 1A is screening, ICD-10 diagnosis, and excuse me, 1A and 1B, 1A and um, 2A is the list of the screening diagnosis, and 1B and 2B is also the list of the diagnostic procedures. So it's very simple division. One is for screening, one is for diagnosis. And then we also have 1C table, which is the table for all the colposcopy and biopsy procedures. That's how it is divided. So instead of listing multiple codes for each procedure, we group them into, screening and diagnostic tables. And, please, maybe after this presentation, you can look at those tables and it will start make sense, why we group them together and what needs to be listed. Any questions here? Okay, so let me, apologize. Oh, by the way, Erin, are we recording this?
Yes.
Okay, great. Okay, so let's talk about, breast services, screening procedure. So during the office visit, PCP should offer counseling to all the recipients about the age of initiation of the screening, frequency of the screening, and individual breast cancer risk assessment. And we already talked that, this consultation may happen not necessarily before the screening, but it can happen even, after the mammography. So the sequence of the events doesn't really matter. But what is important maybe at the initial visit that women understand their risk. They should understand, whether or not they should start screening at age 40 versus 50 versus early if they have concerning breast cancer history and can be considered high risk. And also, they should be consulted about frequency of the screening. And after mammogram is done, providers should also give the guidance to the patient how often the woman should be screened, because we know there can be situation when not routine screening is being recommended, but a short-term follow-up, like, within 6 months to 12 months or immediate workup. So all those things are very important. And again, we not necessarily, requiring providers to see patients before mammography, but definitely there should be a follow-up after the mammography with the recommendation from the provider when women should receive the next round of imaging. So screening mammograms and screening digital tomosynthesis, and we will talk about what screening digital tomosynthesis. So hold this, thought. We're going to talk specifically about what this terminology means at our next session, because that would be a clinical session about screening guidelines. So screening mammogram and screening digital tomosynthesis is available starting at age 40 and is payable once a year for recipient average risk. And we have to kind of assume that every single woman is at least average risk. There is no women that are low risk, because being a woman and her age are the major risk factors. So every single woman is at risk for the breast cancer. Nevertheless, we also have women who are at high risk, which is more than 20% possibilities of developing breast cancer in the lifetime. And those people who belong to a high risk, again, we will talk about high risk later, their screening schedule is different. So not only they're eligible for a mammogram or digital tomosynthesis, they should also receive screening MRI. So both of these procedures should happen at least once a year. And the way how providers do it, sometimes they do both of the studies at the same time. Sometimes they break down and do mammography, let's say at 0 months, and then at 6 months they do an MRI. So any of the schedule is acceptable, but the bottom line that women who are at high risk, they absolutely should be getting screening mammogram at least once a year with both of the modalities. And just a few words so you understand what we're talking about. People at high risk are those who either carry BRCA mutation, or they are first degree relative of the BRCA mutation carrier, or they have other risk factors that put them into the category of 20%. And there's a lot of different models. Unfortunately, we don't have one unique model that can calculate the risk. And depending on the module, women can be lower than 20% or higher than 20%. So usually what we say that if women have multiple risk factors, she should be referred to a formal risk assessment. And they are usually done either by genetic counselor or people at the breast cancer centers, or those who have been trained additionally in those models, who can interpret those models. So it's not, unfortunately, the skill that every single provider has, although every single provider have, ability to educate themselves about those risk models. But unfortunately, right now, not everybody, have this ability. And if they are concerned based on the history, they can refer women for the formal risk assessment. And the risk assessment is pretty much just, getting the history, putting those things into the different models, running these models, comparing these models, and deciding on the recommendations. Any questions for the screening services for breast? Okay. So let's talk about diagnostic services. So for diagnostic services, what we have to remember that there is absolutely no age limit, no frequency limit, and actually no gender limits. When do we use the diagnostic services? We use diagnostic services when our screening results are abnormal and we have to do additional follow-up studies to come up with the final diagnosis. We also use diagnostic services when somebody is symptomatic, and we talked about that. So we use screening services when the patient don't have any symptoms, and we try to find the disease early before it shows any signs or symptoms of the disease. But when people do show up any signs of the symptoms, we absolutely, at no circumstances, can no longer use screening services. We have to go to the diagnostic services. And with breast, we always start with diagnostic mammogram. So it's important to understand that there is a screening mammogram and there is a diagnostic mammogram. And if somebody comes to us with the symptoms, they will be sent to a diagnostic mammograms that has additional views to a regular screening mammogram. The same thing that if somebody has an abnormal screening mammogram and it's abnormal, the next step will be a diagnostic mammogram. So breast cancer imaging that is included into the diagnostic can include tomosynthesis that we mentioned before. Um, and we do the screening, excuse me, we're doing the diagnostic mammograms if somebody had something abnormal in terms of their symptoms, or if something was found on the clinical breast exam, which again is no longer recommended modality, but it can be offered and it can be performed by a provider and based on the abnormal, screening mammograms. So once we identify the lesion that can be biopsied, we proceed to a biopsy, and we cover different biopsies. We cover fine needle aspiration biopsies. We cover core needle biopsies, which can be done including imaging or without imaging. It really depends on the location of the lesion, whether or not, we can palpate it and we can, safely perform core biopsy without imaging. But if this lesion is not palpable, we cannot really, feel it, then we have to do the procedure under, imaging guidance. The other two procedures is incisional and excisional when we have um, the lesions that are relatively large that you can either incise or excise completely. And then next step after the biopsies, of course, everything goes to pathology and immunochemistry where we can identify what kind of, cancer we have. And the last procedure that I want to mention is the MRI. And we just talked about the fact that people at the high risk can get screening mammogram. And then we can also use MRI imaging as the diagnostic procedure. But we don't define between mammogram if it's a screening or diagnostic in terms of the code. So the code is not different for MRI. It's not screening or diagnostic. It's a few codes that basically just states MRI procedure, but it can be used to assess the area of the concern on the mammogram or to evaluate the client with the history of breast cancer after completing the treatment. So when radiologists are unsure what they see and they want to have more accurate reading, they can order diagnostic MRI. Any questions here? Okay. Services that we do not cover, but you may receive questions. We don't cover chest X-ray. We don't cover blood test. We do not cover thermography. Unfortunately, at this moment, we don't cover any genetic testing, including BRCA testing. And of course, for the treatment services, we refer to BCCTP. Let's talk about cervical cancer procedures. Of course, you probably already know everything that we covered. Nevertheless, let's repeat it. So according to the guidelines USPSTF, and we are following USPSTF guidelines, which is United States Preventative Task Force recommendation. We will talk about, why this recommendation, who is in the group of USPSTF, why this recommendation, why not American Cancer Society, how they're different at the different session. But at this moment, we're following USPSTF, and according to these guidelines, PAP test should be covered to anyone starting age 21 and older. Starting at age 30, we're covering HPV testing. It can be either co-test or primary HPV testing, and it's only available for women age 30 and older. And as I mentioned in my previous session, we don't have upper limit because due to the nature of our program, we cover women who are rarely and never screened. Therefore, we don't have upper limit. But at the next session, we will talk about, when usually screening should be stopped. So screening usually ends at age of 65 for the individual who had adequate prior negative screening. What does it mean, adequate negative prior screening? It means that in the last 10 years, a woman usually has 3 negative consecutive pap tests or 2 negative co-test or primary HPV testing, and the most recent one occurring in the last 5 years. For those individuals who did not have the adequate screening, we continue the screening until, we meet this criteria for 10 years of negative screening. And that is also, for women who didn't have precancerous or cancerous lesion in the past. Because women who had cancerous or precancerous lesion will be surveyed, for a longer period of time. So let's continue. For individuals without cervix, and we're going to talk about it again at length at the next session. But what is important to understand is that women may have hysterectomy, meaning removal of the uterus. And oftentimes they may not know if their cervix was removed or not removed. Uh, they may have doubts. If a provider does not have a medical records that document what kind of hysterectomy was performed, we should not assume that the cervix was removed. And we absolutely have to check on women without any medical records whether or not there is a presence of the cervix, which means that the provider should perform pelvic exam and look for the presence of the cervix. And then patients with the total hysterectomy, including removal of the cervix, should not be screened. So if cervix is out, they should not be screened. With a very important caveat, these women should not have a history of high-grade precancer or cervical cancer. So if the woman, the reason for her hysterectomy was precancerous or cancerous lesion, they should continue the screening even if they don't have the cervix. And then if we don't know why hysterectomy was performed, so the reason is unknown and the medical records are unavailable, providers should always assume the worst, that the operation was done due to the cervical cancer, and they should continue the screening on women who don't have the cervix, don't have the uterus, and don't have any documentation. Any questions here? This is very important topic, and you kind of have to approach it with like step by step and understand that we oftentimes deal with women who cannot bring any records. So again, if we don't know the reason why the cervix is out, we should assume the worst and continue to screen women. Any questions?
I have a question, Dr. P.
Mhm.
I encounter a lot of women that have hysterectomies, and as you've mentioned, they don't really know what kind, if it was complete. Would you say it's a good recommendation for them when they're coming in, if they've been rarely screened, to get that pelvic exam so that way they can ask for that?
Absolutely.
Okay.
Yes. So they should get the pelvic exam, and they should, and the provider should look for the presence of the cervix. If the cervix is there, the recommendation would not change. Cervix means, the area where the cancer can grow still exists, and they
Mhm.
should continue screening, until either age of 65 is an adequate screening, or until, these 10 years are completed. And if there is absolutely no way that we can get the documentation for the operation and the reason for that, because sometimes it can be delayed, it can
Yeah.
be you can get it, but if you absolutely
Yeah.
cannot get it, provided you assume the worst, and they should continue the screening of the blind pouch of the vaginal wall that is left after the operation. And we will talk about it more, so we will have another opportunity to kind of step by step to go through this. But it is important to continue screening women, because we absolutely cannot guarantee that it wasn't due to a cancer, that let's say it was due to maybe endometriosis or fibroids. So we have to make sure we're screening women appropriately, which is a kind of difficult screening, because you have to take the swabs just kind of blindly on this pouch, and sometimes people even do colposcopy without looking at the cervix, but colposcopy of the of the vagina. But yes, that's very important, because even if the cervix is no longer present, HPV virus can still harbor in the cells of the vagina.
Thank you.
Okay, thank you so much for your question. Um, So when we're talking about high-risk patients, so these are patients who are either have been exposed to diethylstilbestrol, which was the medication used in 70s to improve fertility. So not a lot of women actually, in this category, but it's important to ask whether or not their mothers have been exposed to that. So it's not the woman themselves, it's their mothers who've been treated for that. And that's kind of a risk factor on its own. It's also immunocompromised patients. It's either patients with HIV or those who take immunosuppressive therapy if they have any kind of autoimmune disease. And of course, it's the patient with the history of the cervical cancer. Patients over age 65 determined to be high risk are in need of long-term surveillance for the previously abnormal results and should continue to be screened. What is important to remember that sexual history or change in sexual partners or increase in the number does not put patients into the high risk category. Okay. So let's talk about diagnostic things. So of course it's HPV, genotyping, and again we will talk about what HPV genotyping is, but we have high risk and low risk HPV. And if we identify the most commonly found high risk HPV, which is 16, 18, and 45, with type 16 and 18, the recommendation is usually to proceed to colposcopy right away because more than in 70% of the cancers, we can find either type 16 and 18. Knowing how much these types weight in terms of developing of the cancer, we don't usually wait. We immediately jump to the colposcopy. So genotyping is the next step after we receive positive, HPV uh, either as a primary or as a co-testing. So we cover colposcopy. It can be with or without biopsy, and I think we talked a little bit about it already, but we will talk more about it. And it also can be done with or without endocervical curettage. And the cervical curettage, when you go kind of, deep in the canal, either with a brush or with the curette and scrape the cervix, inside the canal, making sure that we did not leave out the transformational zone. Because oftentimes, when you cannot find the transformational zone where the epithelium from inside the cervix connects with the epithelium outside the cervix, this is the zone that we call transformational. This is where the epithelium change all the time because of the different pH and different environment. And this is exactly where HPV harbors, and that's where the usually those changes can lead to precancerous changes. So if you don't see this transformational zone, which can be seen with the naked eye, and of course much better with the colposcopy, but if you're not able to see this zone either with the colposcopy or just with your naked eye, then you have to make sure that you scrape inside the cervix to get this transformational zone out. Otherwise, you may miss a cancer. Of course, we cover pathology, and we also cover P16 immunochemistry. I will spend, just a minute here to explain what this immunochemistry is. As you may know, we divide cervical precancer into three stages: CIN1, CIN2, CIN3. And usually CIN1 means that the virus is there, but it doesn't really change any cell. And CIN3 is the precancerous lesion that needs to be treated. And the CIN2 is something in between. And sometimes, there is a huge intra-observer variability. So different pathologists, can call CIN1 as CIN2 and call CIN3 as CIN2. So everyone reads pretty much very subjectively, which again is an opportunity to kind of misnomer the lesion and call something that is high grade lower grade and something that is lower grade higher grade. and which can lead to mismanagement, either missing of the cancer or aggressive procedures that can influence, future fertility. So luckily, we have now an instrument which is a special dye that can help us to stratify neoplasia either into the low grade that require an observation or high grade. So when you dye cells with the special immunochemistry dye, really those lesions that are low grade will not be overread as CIN2. And those that are really high grade lesion will not be downgraded to CIN2, and patients will be, treated appropriately. So we're doing P16 to make sure that we put them either into the low grade category or high grade and try really avoid, CIN2 as something that can mislead us and can kind of stop us from or delay our appropriate management. Also, sometimes we can get endometrial cells on the pap test, and we don't and those cells would be abnormal, but we don't know the nature of these cells. So when we see those cells, glandular cells on our pap test, we also want to exclude endometrial cancer. So when we have glandular cells, abnormal glandular cells on a pap test, in those cases, we allow to perform endometrial biopsy for the work of abnormal glandular cells. And again, we cannot cover um, endometrial cancer. Nevertheless, we have to exclude endometrial cancer and make sure that, the AGC is due to the cervical cancer. So one way or the other, we get into the diagnosis. But if we will get the diagnosis of endometrial cancer, unfortunately, our program will not cover that cancer, and we have to help providers to find, different, source of the coverage. Any questions here? I know it's a lot of materials, it's kind of heavy. So again, don't hesitate to ask any questions or, go over it, on your own and then ask me questions at the next session. So services that we do not cover, we don't cover any treatment, which can be ablation, excisional procedure. So when we do ablation, we pretty much just, freeze or heat those cells. So we don't have any materials to examine. We pretty much just, kill the lesion, in its place. In excisional procedure, all of these procedures are covered by BCCTP, and they include all types of conization, which means incision of the cone, inside the cervix. And these procedures include lip, lids, cold night, CO laser. Usually also we don't perform routine pelvic exam if there is no need for the cervical cancer screening. We also don't cover sexually transmitted disease infection, which is the difference with family pack because they do screen for sexually transmitted infection, and we do not cover pelvic ultrasound. So anything that beyond the scope of the screening recommendations, and you have to understand that the recommendations are different from screening to diagnostic recommendations. So if we're talking about management of any abnormal pap test or HPV, we have ACCC guidelines for managing abnormal cancer screen testing results and cancer precursors. And last time, I think both of you were at this session when we've talked about that those guidelines are available online, and they're also available as the downloadable application for $10, which my understanding is reimbursable through your contract, where you put a history for a woman, and the application will provide you individualized approach to the cervical cancer management of the abnormal screening results. So I highly encourage each of you to have this application just in case, because we do have the case of some providers here asking for our guidance. It doesn't mean that you will put it in, you will run it and give the recommendations, to the providers. I encourage you actually to consult with me, if you have any questions. But it is really very useful application in case you want to find out, how certain patients should be managed, and it kind of, can either confirm that the provider is, using those guidelines, or provider may deviate, and they may deviate for, a good reason. But again, this is something that I think is absolutely useful and helpful in your work as the consultant for the regions. If no questions regarding covered services, we're going to talk about case management and patient navigation. Any questions so far? Okay, moving along. Okay, so why we use these terms interchangeably? I think the reason for that is that those terms at different times were utilized by our funding agency, National Breast and Cervical Cancer Early Detection Program. And at some point, they called it case management. Then later, they decided to call it patient navigation. But these terms are really interchangeable, and oftentimes, you will see that the clinic may use one term versus the other. And for example, in our program, we don't pay for patient navigation, but we pay for the case management, which in a nutshell is the same thing. But let's talk about what it is. So the goal for the case management patient navigation is to ensure a patient receive timely and appropriate screening services so that they can return for teen screening, diagnostic, and treatment services by helping EWC recipients to identify and overcome barriers to achieve screening, definitive diagnosis, and treatment. So, what are, excuse me, what are the to barriers to access, our services? Um, we listed a few, which are the major ones. It's the transportation, and that especially true in the rural and frontier areas. It's usually the scheduling because, for people who work or who provide daycare or adult care, it's difficult to get out of their, work environment or house, at the time, when clinic is open. That's why it is so important for our clinic locator to list clinics that work outside of the regular hours. Of course, as I mentioned, it's child care or elderly care issues. Huge barrier, of course, is the cultural beliefs and cultural approaches because, even now in many countries from where we may see the immigrants, breast and cervical screening is still not a mainstream, or at least it's not a mainstream in terms of, providing mammograms. So it's also lack of understanding of the value of follow-up procedures. So people can get screening procedures and they kind of disregard, um, you know, providers' recommendation for, additional workup, because women, may say, "Oh, I feel fine, and I'm not going to go and get, the next procedure." So there is quite a lot of barriers, and our goal is to empower our providers to have a really good tracking system and system in place to be able to eliminate those barriers. Um, and sometimes that's not easy because we don't have any additional resources like, paying for transportation, for example. In some states, they do offer that, but unfortunately, with our very definitive budget and budgetary problems in California, we just don't have any means of sponsoring transportation and vouchers for public transportation or Uber or taxi. So one of your major role that we see is when you go and orient new providers or existing providers is to make sure that they have a really strong recall tracking and follow-up system. And what it means, we need to ensure that all the screening tests and all the necessary follow-up services are completed, and that there are people who monitor patients going through this, circle of the events. We need to bring patients back for the next routine screening as well, notify patients of the results in timely manner. And it's interesting that, for example, you may know that all the mammography results, they have to be delivered to patients via mail. Patients have to be notified in writing, and every single radiology facility must do that. And it's up to our um, primary care providers to ensure that uh, you know that not only radiologists inform women about it, but that the primary care provider, reach out to the patient to kind of, build up on the plan for the, next either routine, short term, or immediate workup. Because regardless what referral providers do, it's still the role of the primary care providers to ensure that the patient has the plan for the future, screening or diagnostic procedures. So, of course, this tracking system should follow up whether or not the patient referred to diagnostic and treatment if necessary. And all the contacts with the patient should be recorded in the medical records. If EWC providers are interested in creating and printing reminder recall cards, we have those cards available on our website, and you can go to this link and get those cards from there. We've talked about it already before, and we've talked about it when we were talking about PCP duties and responsibilities. But let's just, summarize again that notification of the patient is super important, and we expect that the normal results will be conveyed to a patient within 30 calendar days, abnormal within 2 weeks, which is 14 calendar days, and the cancer immediately, but no later than 7 days. And all of the contact with the patient should be documented. Let's talk about quality standards in terms of timeliness. Again, timeliness very closely correlate with the notification. So if somebody needs a diagnostic evaluation, it should be done no longer than within 14 calendar days. And the time between, final diagnosis, from the abnormal, to definitive diagnosis should not be more than 60 days for breast and cervical results. The same thing, referral to the treatment should be done within the same 7 calendar days from the receipt of the final diagnosis. And the treatment should begin also within 60 calendar days from the receiving either breast or cervical diagnosis or precancerous lesion. So in regards to the treatment, patients should be referred for treatment, and we have a special program, BCCTP. Interesting fact that when our program was originally established for quite a few years, we did not have a treatment program. So we, the program was really in a catch, 22, because you cannot, you're diagnosing the patient with the cancer, and there is absolutely no cancer treatment program that will take people with, with this eligibility criteria for treatment. So luckily, or thanks God, or thanks to legislature and advocates, BCCTP was established. Here is the link, and we will talk about referral to BCCTP at the next module. What is important to remember that and I think I already said it, that every single patient that apply for BCCTP should also apply for the Medi-Cal. If they don't apply for the Medi-Cal, their application will not be considered for BCCTP. So this is step number one when applying for BCCTP. So in regards to the patient notification, this is also a very hot topic because we discovered that not every single provider doing what we require them to do, and this is also part of our regulations. So there should be at least 3 attempts to contact the patient, and we really don't advise what kind of attempts it can be. So it can be phone calls, it can be messages, um, through the EMR portal, electronic medical, portal, if patient is registered. But we want to make sure that we're protecting patients and the providers by asking them to make the last attempt as a certified letter. Because if the certified letter returned without the signature, it means that patient was not found and we really were not able to find the patient. But on the other hand, if it comes with the signature, it means that patient has been notified, and it's really patient's responsibility to do next step about either abnormal results or cancer diagnosis. Any questions regarding patient notification? Okay. Let's move on. Um, so recipients that require immediate workup, we sometimes, unfortunately, find that patients can refuse care, but the refused care is the term from NBC-CDP, from our federal funding agency, and it includes too many categories. And right now we are trying to see if we can break down those categories in the past, so we have more accurate count of what really happened to the patient. But at this moment, it's kind of a very convoluted term, and when we do our monthly CPPI follow-up reports, trying to make sure that patients receive adequate care, we really try to distinguish what it means refuse care, because it can be really literally that the patient verbally refuse care. They say, I'm not going to follow up, I'm not interested, I feel fine, I refuse this care. But it's also the patients who are getting medical or another insurance. So patients continues to get, all the appropriate, diagnostic services. Nevertheless, for us, this patient is kind of lost, but we call them refused care because they went to another medical insurance and we are no longer paying for this patient. It also can be change of PCP for any reason. Patients can move, patients don't like their PCP, other circumstances. But as you know, when patients move to another PCP, they have to re-register with the existing EWC ID, but with the new provider, and this new provider will start the new cycle. So for that cycle with the old provider, that means that the patient refused care because they moved to another PCP. Also, it may be patients who can be found, but patients not necessarily verbalize you that they are refusing care, but they just keep failing, show up at the appointments, or they fail to respond to telephone messages or certified letter, but you can see that the letter was delivered. So it's kind of like refused care by default or silently refused care. And of course it can be also due to the fact that patient moves either within the state or outside the state. So again, we are really trying to go against the current and create more fields. So we record that, more accurately and report it to CDC more accurately, but CDC does not have a place yet, even in their system, to record it. But I think that this may change because we find a lot of patients with the medical expansion that moving to medical or another insurance, through Covered California, and we're really losing the patients. But the way it's labeled, it's not really accurate. So please, keep it in mind that for now it's still refused care. But when it comes to monthly report, we will ask you to document it more accurately, and hopefully in the future there will be something like a drop down in DTAC. I apologize that I'm spending so much time on that, but this is really hot topic that we pay a lot of attention to making sure that we're not failing CPPI, because it appears that we may fail CPPI, but the reason would be that the people just move to another provider or another insurance. Another category of this status is lost to follow up. So again, this is usually when recipient require immediate immediate diagnostic workup, but they cannot be reached. So we cannot find the patient. We cannot locate the patient. It's either a telephone is disconnected and no longer can be reached. They no longer can be reached, by the phone that they gave us. Um, we have to document every single attempt and what was the message on the phone. The same thing comes with the mail. We're sending the mail, but the mail, returns, back to the sender. And when we do the last notification with the certified email, it returns undeliverable without the signature. So those patients are considered lost to follow up. Any questions here?
Svetlana, I don't have a question, but I I do have a question for Brianda, and that is for the health educators. You have a similar terminology for navigation when you do, I think, 3 attempts to contact somebody. Can you just tell us briefly what a contact entails, if it's a text or leaving a message?
Yeah, so it's a lot similar. Phone calls, text messages, face to face. Sometimes if we have a regular location, um, that's where you're able to find them again. Or if you know that they frequently go, for example, if they go to like a transition house regularly, then they'll come back in. That's kind of the ways that I similarly will document the attempts. They do get lost if you try to contact them, but oftentimes I'm finding that it's really the time of day or they're busy working or that's why they don't get to reach and to pick up those phone calls. So oftentimes I'll ask, what's a better time for me to find you, or what's a good place? Do you come here regularly, or let them know if it's somewhere that I visit often. That way they can find me again. Because oftentimes I find if I give my phone number, they don't reach back. That's kind of I do similarly things like that.
We document that on the initial form that we have, where they give the consent, the health education form. We make little notes on that too, so that we can track it if somebody else were to pick it up, because we try to finish all that follow-up for screening assistance within a certain period. And we have been lucky. We've waited as long as a month and finally reach people, which is always really good. And but we do try to so that if she makes one call and I make another, for some reason, we will know where how we've been reaching the patient successfully, and then track it that way.
Thank you so much for this insight. It's really, great to hear that you're not giving up and, able to reach patients even after, some prolonged period of time.
But I think they also do get lost. I've had a couple of them where, they do not return the phone calls, but eventually months later you'll find them again, and then you kind of restart it again. So I've had a couple instances where that happens, and so you still kind of keep working with them.
Thank you so much, Brianda. Well, I guess, not a lot of, providers, really have the opportunity to, to follow up patients indefinitely. But what we found out is that it seems like our providers so far have been doing really great work of following up with the patients and trying to find them and document appropriately. But we had some issues with Planned Parenthood, but I'm not gonna, go into that just because we have limited time. But we're happy to share with you our findings, maybe during our regular, meeting at our monthly CC conference. But uh, Planned Parenthood have some very weird not every single Planned Parenthood, but very weird way of recording it. So they record as a like the first meeting with the patient. They record as the first follow up, and they don't do calls and they only send letter, but not certified letter. So we have some issues, but we can talk about that. And if you come across of the Planned Parenthood in your region, I think that you have to be very accurate in terms of how to approach them. And, in the future, we have some measures, how we're going to talk to the Planned Parenthood and try to really convince them to follow up more appropriate, tracking system, because first of all, not only it protects or give an opportunity for the patients to really receive their diagnosis, because no phone calls and one letter is really not enough to inform patients about their diagnosis, but it also protects the provider from any kind of lawsuits, and provides them liability. So that's important to remember. But if you come across of the issue of bad tracking, not appropriate tracking, please bring them to us. Okay, you're not alone on that. All right, moving along. Okay, let's talk about, treatment program. Very interesting topic. So, VCCTP is a really, very different program. And I always advocate for us to be, under the same division and be kind of, natural extension, one of another. But they are in a different division and they belongs to eligibility division. And the way they work, they don't have the same breakdown of what we have into teams. They pretty much have eligibility workers that go through the eligibility criteria and make sure that they enroll patients appropriately. Therefore, we, meaning our program, and especially clinical coordinators, is really the extension of BCCTP, and you're the ones who are educating providers about BCCTP program. So in so many ways, you are extension of this program, and it is important to understand some nuances of their eligibility. So again, I mentioned that, we didn't get this program right away. We started in 2093, and the program was in statute in 2001 and started to work as of January 2022. We listed the phone number, email, and fax, and of course the web page that you can access. So the screening criteria are pretty much, well, they are the same, although the the family income, they define a little bit more strict than us, and they also verify, income and the immigration status. So they work differently from us in terms of that. In order to get enrolled, they verifying, the application, and they need the supporting documents, while we don't ask for that. So again, same criteria: California residency, gross income, based on the family size, below or equal to 200% of the federal poverty level. The chart, the numbers are the same. Applicants should be found in the need of breast and cervical cancer treatment. And what is not part of our screening criteria, but the part of BCCTP criteria, individual does not have a full scope of medical benefits. So how to apply for the, excuse me, how to apply for BCCTP and how to start with applying for the county medical. So applying for medical is BCCTP requirements. And as I mentioned before, applicants should be denied a full scope of medical. When people are applying for the medical, eligibility workers must print and provide the instructions how to apply for the medical. And EWC beneficiaries found to have qualifying diagnosis who have not applied within 30 days should be instructed to either reapply or apply for the medical again. If they're found eligible, they will be enrolled into the medical, and therefore they will not get enrolled into BCCTP. And as we can see, quite a lot of patients actually coming from our program of Family Pact are getting medical at the end, which is a very good news for them because they're getting most of the time comprehensive health coverage. Let's talk a little bit about presumed eligibility. So presumed eligibility allow people, start getting the benefits right away. this is crucial. This is so important because we're talking about, breast and cervical cancer. So usually when people, have a diagnosis, either referral or primary care providers immediately send them to the treatment, and people can start it right away with some exceptions. So this is a temporary benefit, and they start on the day you apply for BCCTP. They end the last day of the next month if you do not apply for the Medi-Cal. So you have to really kind of calculate depending when you start, but you may have as many days as 60 days if you apply on the first day. Let's say if you apply on the 1st of November, the eligibility will end on the 31st of December. But the later in the months you apply, the fewer days you have for this temporary benefit. Presumptive eligibility will extend if you apply for medical at your county social services by the last day of the month after the month you applied for PE. Unfortunately, PE benefits, we are not available for people who are age 65 and older, who have Medicare or private insurance, have hospital emergency or pregnancy presumptive eligibility benefits within the last 12 months, or identified in medical database as having unsatisfactory immigration status. So again, not everybody will get presumptive eligibility, unfortunately. But if you remember, our rule for starting the treatment is 60 days from the diagnosis. And the rule for the BCCTP in terms of, application, how long presumptive eligibility is also along this, 60 days. So people who even not eligible for presumptive eligibility, if they, collect the documents in time, should be able to start the treatment within 60 days. So providers can continue to enroll qualified, applicants into BCCTP. If eligible, BCCTP presumptive eligibility will continue until the medical eligibility decision is completed by the county. Majority of BCCTP applicants can start the treatment while the application is being reviewed by BCCTP, with the few exceptions as I mentioned. If individual applied for the medical after PE has ended, then they should reply for BCCTP again. 3 ways of how to apply for BCCTP. This is also a super important topic. So there's really, only 2 major gatekeepers to BCCTP. So the access to BCCTP application is only available for EWC providers and family pack providers. So usually people get to the program either through us or family pack, and we know that family pack does work somewhat differently than us, and it seems like they don't really train their providers to enroll patients into BCCTP. And I think that, I don't want to, speak about other program, but anecdotally, it seems that some providers don't even know how to do it, and some providers may be very experienced how to do it. So it's kind of hit and miss, but we're working with BCCTP and family packed, and actually this module that I'm presenting to you will be available, to family packed as well. So more providers can kind of realize that they have access to BCCTP and can enroll patients. But again, they only enroll patients who are diagnosed with the cervical cancer because they don't provide breast cancer treatment. So in a nutshell, we're probably a larger entity that provides patients to BCCTP. But what happens if patients diagnosed outside of BCCTP, but by eligibility criteria, if patient is diagnosed with the cancer outside EWC or family pact? So outside, maybe in another state, or, maybe they have insurance and they lost this insurance. So they are diagnosed with the cancer, but they're not our beneficiaries or family pact beneficiaries. What's going to happen to them? In the past, they were ultimately sent to our program. And for multiple reasons, our program should not be the most appropriate agency who should handle those enrollment. Um, Reasons for that is, first of all, it's a liability. So if you see the patient that you didn't diagnose with the cancer, but all of a sudden you kind of become their primary care, but only for the reason of enrollment, it's your liability. You don't want to be primary care provider just kind of administratively and later have patients sue you for maybe not explaining things to the patient, or patients didn't start the treatment. So there is a lot of caveat why we cannot be really considered primary care provider and shouldn't be doing this courtesy enrollment. Secondary, there is no reimbursement for that. We still have patients who do come to primary care providers, EWC primary care providers, and those providers kindly enroll them only because they don't want people to go in circles and circles, trying to find the place that can enroll them. So we do this have occasional courtesy enrollment of these patients, but we really not necessarily support these practices because it overloads primary care provider system and may put them at the risk. And we really appreciate providers who try to minimize the administrative burden of the patient with the cancer. But we created the new system with BCCTP, where patients should go to eligibility offices where they can apply for Medi-Cal and BCCTP at the same time. So that's the most important caveat, and it should be done at the Medi-Cal offices or through online. Um, as I mentioned, some clinics are very savvy and they also have certified enrollment specialists who can submit medical application on site without patients going to the county medical offices. So, of course, for the offices that have certified enrollment specialists, it's a blessing. Any questions here in terms of, where we should be sending people who've been diagnosed outside, that we really try to give it to the county eligibility workers. And I want to add that these workers, they don't have access to BCCTP portal, so they don't really enroll patients, but what they do, they collect all the documents and they send them to BCCTP, and BCCTP as the program enroll them directly into the program. So don't expect or don't assume that eligibility workers will enroll patients. They will just be the kind of a middleman to deliver all the documents, to BCCTP eligibility workers. So I kind of already talked about it. So if our providers has been approached by someone diagnosed elsewhere, we refer them to the Medi-Cal. And what is important to mention that applicants should ask eligibility worker to help them to apply for the Medi-Cal and enroll them into BCCTP as the county referral to BCCTP. Also, patients should be advised to have a copy of their pathology report, because without report, we don't have a confirmed diagnosis. And also, these people should have name of the diagnostic provider or healthcare organization. Again, if our PCP that have been approached decided to enroll patients into BCCTP, we are not against that. We just don't encourage that to be done kind of in a massive way. But we also want to save patients from additional trips if provider is willing to do that. The reason I spend so much time, because there have been, a lot of discussions and there is a lot of scenarios, and we really try to be open-minded and help people as much as we can, but at the same time have a, kind of more controlled process of how these people diagnosed with the cancer elsewhere, can get help without going into the circles and, trying to find providers, trying to reach BCCTP who refer them back to EWC. So we try to straighten out the process and make sure that there is definitely, ultimately, entity that can handle those cases. So let's talk a little bit about, difference between federal and state BCCTP. So there are, two different BCCTP. Um, and we also have federal and state funding, but we don't really identify or bring patients into the category of federal and state. And BCCTP have to do that. Um, because when somebody goes into the federal BCCTP, it's going to be a full scope medical. So it means that people will get full scope without any constraints. And they not only going to receive a breast and cervical cancer treatment program, but other non-cancer healthcare services who are qualified besides the criteria that I mentioned before. So it's all people who are uninsured, who are under age 65, so those who don't get Medicare, and also U.S. citizens and nationals, and those who have satisfactory immigration status. But as of January 1st, 2022, some of the individuals up to the age of 65 who meet some of the points above may qualify for the full scope medical, even if they don't have satisfactory immigration status. This is really, something that is being reviewed on the individual, basis. State BCCTP, it only gives limited scope medical, which means only breast and cervical cancer treatment services or related services will be covered. Who will be eligible? Uninsured and over age 65, or those others who have health insurance such as Medicare or private insurance, regardless the age. Okay, and there is also such thing as retroactive eligibility the same way as we have it for EWC. So if individual receive medical treatment or services before they applied for the Medi-Cal, before they apply to BCCTP, Medi-Cal will cover the cost of the medical care up to 90 days before their application date. It's called retroactive benefits. Recipient must apply within 12 months from when they receive the services. To qualify, for this retroactive eligibility, they have to meet again certain eligibility criteria. Age under 65, screened and found in need for treatment by either EWC or family pact or by any other entity that diagnosed them with precancerous or cancerous condition. Those who did not have a health insurance covering those services, they need to be California resident and receive services from a medical provider. And as I mentioned before, starting January 21st, applicants may be eligible for the full scope of medical, even if they have unsatisfactory immigration status. So that's important to remember because, quite a lot of people start receiving, medical treatment, before they receive full scope medical. That's why retroactive eligibility is so important. Any questions here?
Dr. Popova, sometimes we have women who are eager to get started with treatment and they will self-pay. And will they be able to be reimbursed?
Yes, well, I'm not sure if they will be able to reimburse. It's actually a very good question. I don't know if I will ask this question BCCTP because I know that they're not supposed to pay out of pocket, that their provider can get reimbursed. Because the
Okay.
way Medi-Cal works is that we don't have a mechanism for paying people directly. Like,
Mhm.
for example, when we're talking about underinsured, we cannot reimburse out of pocket portion. We have to pay for the entire service, but we only can pay to the provider. We cannot pay to a patient. And I think it's the same case with BCCTP. Um, Therefore, it is, really important to to have the relationship with the provider where they don't balance bill and they wait for patient's insurance to kick
Mhm.
in. So, um, really good question. I'm really glad you asked that because we have regular meeting with BCCTP and one is coming up So I'm going to ask this question about what's going to happen to people if they start paying out of their pocket. I am very concerned that the answer that they cannot reimburse to a patient, but I'm going to find out. Or maybe I can find out what other recommendations for people who are forced to, to pay out of pocket, because maybe there should be something more in regards to advertising these retroactive benefits, or maybe
Mhm.
educating providers about it, um, or sending them to to the website regarding this retroactive benefit, or maybe even talking to BCCTP that can. I don't think they can really assure, but they can tell that if patients if patients is eligible, it should not be a problem. So
Okay.
you bring up a really, really good point. We absolutely don't want our patients, to delay their treatment services, but self-pay, I just cannot imagine how much it can be.
And then
Probably terrible.
I have a
Absolutely.
question also. Is the application for Medi-Cal when they're applying in conjunction with BCCTP expedited? I've had a couple of people when I'm at events that are still waiting for a decision from Medi-Cal. And they're waiting for their decision, and I can just imagine these patients that are with the newly diagnosis, if there's a back.
I think it's very difficult for me to, you know, to answer your question, because I have to speak for, another program. But again, let me ask BCCTP how people can find out about the status, whom they should contact. Most of the time it might be advancement, and patients advocates, but let me find out about how patients can verify their status and speed up their application process.
Thank you.
So sorry, I don't have the answer, because it's very difficult to answer for someone. But usually, this kind of questions is exactly what we're looking for, so we can clarify with BCCTP. And they also, BCCTP as the program, are also, really eager to receive those questions and work with us, because again, they don't have their like hands, ears, and eyes in the region, and you're the ones, so those questions will be appreciated. And if it's not too difficult, do you mind just sending us an email, because it's always better to have a paper trail, um, and we can send them forward, just not to forget, because as I am presenting things, I'll try to remember, but I don't want to forget about it, and I want to follow up and have it in writing and as an agenda item. Thank you so much, Brianda and June, for that. Sorry, I put myself on mute. So with that, let's continue. Claims and reimbursement. So of course, only people who are enrolled with EWC and who have valid NPI with DHCS and EWC can bill us. We're using the same type of the claims form. It's either CMS 1500 or UB04. Every provider have to make sure that ID for the recipient is not expired, and that it's put on the claim, and ensure that the NPI on the claim matches with the NPI where recipient received the services. So usually, majority of the providers submit copies electronically, but there is also a hard copy, in case, somebody needs to submit a hard copy. Um, Electronic billing goes, per Medi-Cal electronic, billing instructions. Our process is really not any different in terms of, submitting the claims. The way the claims are adjudicated is might be different, because we have different business rules. So if there is any claims question, they should be addressed to the telephone service center, and only if the telephone service center unable to find the reason why it is denied, and it's something that is beyond their expertise, um, please bring them to us. Usually, we have to elevate these questions to our fiscal intermediary, um, our fiscal intermediary um, liaison, and it sometimes takes quite sometimes to fix the problem. Lately we have not been experienced many problems because we fix our adjudication system, but occasionally those things may arise, and when they are arise, we need to send us a secure email, because oftentimes it's PHI. So remember that it should be always secure. But if we need to investigate something, we would need things like claims number, patient's ID, etc., etc. So all this correspondence should be sent via secure. Okay. So usually what TSC can help us with clarifying billing policies and procedures. They help to log into the medical portal, how to complete claims, how to do the inquiry forms, appeals, and resubmission turnaround documents. You can also request training, with the regional representatives, and I talk about it when we were talking about the resources, and they're open from 8 a.m. to 5 p.m. Monday through Friday. Again, something that I mentioned, all the claims should have CPT and ICD-10 codes, which are found in every woman portion of our medical manual. Only EWC approved ICD-10 codes, will be eligible for the payment. If claims submitted will have ICD-10 codes that are not EWC, those claims will be denied. And it's important to remember that the later the claim is submitted, the lesser will be the amount for the reimbursement. So if the claim is submitted after 6 months, between 7 to 9 months, it will be only 75% of the original reimbursement rate. During 10 to 12 months, 50%, and usually if it's a fault of the provider and they submit the claim after 1 year, it will be 0% reimbursement. If the issue when claims was denied erroneously because of the glitch in the system, then those claims will be paid. So if it's a fault on the department, it shouldn't be a problem. But if the delay is on the provider side, then the claims, will be subject to, deductions. So common reasons for the denials that usually can be solved by TSC: expired or invalid recipient ID, services that have been claimed are not covered or incorrectly billed, they use the wrong modifier, they don't complete ICD-10 code, so they put the wrong ICD-10, or they put the cycle not eligible for the case management. And we will talk about case management later. So you have the number for the TSC. I already said that, if they cannot help us, send it to us. And again, when you're kind of, putting yourself on the front line, please, remember to advise providers that you also kind of, the last resort. So if they cannot solve their claims, they should, appeal to you. So with that, we are at 11:26, and we have a few modules to complete, and I would like to do it at our next training session. I apologize that we're breaking out, but we won't be able to complete it today in the allotted time. Erin, when is our next meeting?
I think it's next Thursday. I can double check.
Okay, next Thursday. So I can assure you that, we will try to complete our orientation, hopefully within this session, but, I'll take a little bit of a time to finish, this orientation and start the clinical portion.